um, that they can watch this later and maybe again at their leisure. So I would just like to start off by welcoming everybody to our Friday CFAR conference. Just a reminder, next week, Dr. Judy Levison is coming to give us an update on the changes in guidance around breastfeeding in women living with HIV. But today we have a very exciting invited speaker, Dr. Monica Gandhi. She's a professor of medicine at UCSF, did her medical school training at Harvard, and then went out to UCSF, where she has done her subsequent residency, infectious disease fellowship, and public health training, and has done just countless really important studies in the area of HIV, with some particular work in HIV in women living with HIV, and also in understanding adherence and very creative ways to measure that, which she has spoken to us about in the past. But I think the one thing about Dr. Gandhi is that I have been the personal beneficiary of her extremely generous mentoring. And I think she is a real model for how to reach out to other junior scientists and to bring all of us along as a community of people working in research and care for people living with HIV. So we are so honored to have you, and we are really excited to hear your talk about injectable therapy for diverse populations. So thank you, Dr. Gandhi.
Well, thank you so much for having me. It's really nice to see so many people whom I know on this call. And we're going to talk about injectable HIV therapy for diverse populations. And I have some questions in here, but I know it's not a strictly ARS format. But for those of you who treat HIV, if anyone wants to, I'm curious if people have started long-acting injectables. They've been out now for about a year and a half. Anyone can say anything or we'll go on, but for those of you who have started it, it's a really exciting time in HIV medicine to have these treatments. So we'll start with a case, 38-year-old gay man with HIV who was diagnosed 2 years ago. He lives with his brother, and he comes from a family with whom he's not comfortable coming out as either gay nor living with HIV. His brother doesn't know his status, and he's simply not comfortable taking oral ART. He doesn't want his family to know, and he's not been on medication steadily since diagnosis. And so this is actually not the patient that fits the clinical criteria of the registrational clinical trials for the long-acting injectables, but he wants to be on long-acting ART. So it's not just stigma, but a number of different barriers, individual, structural level, that affects the ability to take medications every day. And they differ by population. In India, you may be a daughter-in-law who doesn't want your mother-in-law to know that you have HIV, even though the son gave it to you. Or here, at least in the city of San Francisco, I think the three major barriers to adherence are substance use, mental illness, and homelessness. But regardless of the barrier, we are at a point where last year there was a very nice study by Grace McComsey that showed that, at least by pharmacy refill data, 60% of those living with HIV report adherence less than 90%, and 40% have adherence less than 80%. And in terms of rates of virologic suppression worldwide, another nice study in Lancet HIV last year looked across 31 countries. And at least at 1 year, there's a 79% virologic suppression rate. By 3 years, it's a 65% virologic suppression rate of those on ART. That is actually the statistic here in the United States as well. It's a 66% overall virologic suppression rate for those on ART, better in Ryan White care clinics. So we are at a stage where we have these medications, we have oral ART, but there's a number of different barriers that make it hard to take those pills every day. And that's not just true of antiretroviral therapy, but of PrEP. So this was just in the Lancet HIV last year. And same thing, systematic review, 41% of those who started on PrEP discontinued within the first 6 months. And for those who stayed on it, adherence was around 63%. So we have work to do. Oral PrEP is important. Oral ART is important. These have been major advances, but we need other options. We need something that makes it easier. And so there were a lot of meetings. There were a lot of NIH meetings and HRSA meetings and CDC meetings prior to the release of long-acting ART. And a lot of us sat in the room and said, well, we really want to use these for people who have a hard time taking oral medications every day. And I thought of it in sort of a bimodal way. There are people who have pill fatigue but are highly adherent, and they may want the injectable ART, but there's going to be a group of patients with barriers, often structural, to taking ART that would want injectable ART, but that wasn't how the drugs were studied. So if we look at the 3 registrational clinical trials that led to the approval of long-acting cabotegravir and rilpivirine, which was the first combination antiretroviral therapy that's injectable to come out, those 3 trials were performed in participants who were on oral ART and were virologically suppressed before switching over to the injectable medications. The FLAIR study, remember, was that in treatment naive patients. Atlas was in those who were treatment experienced. Atlas 2M was taking that every month in the injection of cabotegravir and rilpivirine and giving a higher dose and giving it every 2 months. But all of the participants in these trials were all virologically suppressed on oral ART before switching over. This was the design of the FLAIR study. Participants were naive, put on dolutegravir, abacavir, and 3-TC, was on that for at least 20 weeks, and then switched over once they were suppressed and at least suppressed for 20 weeks over to injectable cabotegravir and rilpivirine. The Atlas study participants were at least 6 months virologically suppressed on whatever therapy they were on. These were treatment experienced participants, and then they switched over to cab and rilpivirine. And these looked good, of course. Here's the FLAIR week data out to 124. We have it actually out to 124 weeks, and virologic suppression rates were upwards of 87%. 124 weeks was 80%. And then Atlas looked really good, really high rates of virologic suppression if you were virologically suppressed, had experience with oral ART, and switched over. And then Atlas 2M, same thing. It was virologically suppressed participants, either in Atlas or they were enrolled de novo, and they were switched over to cab rilpivirine every 2 months at that higher dose, 900 milligrams, 600 milligrams, and also out to 152 weeks. The data looked really good, over 85% virologic suppression, virologic success. So participants did well in these 3 trials. Now, there was a certain rate of failure, and I want to talk about those failures because it's going to be important to think about the failures when we think about why did the WHO not put on long-acting cabotegravir and rilpivirine onto their treatment guidelines, because they haven't. They put on IM cabotegravir for PrEP, but they have not endorsed long-acting cabotegravir rilpivirine. So what is it about these failures? And anyone can yell this out, but I'd be interested in your thoughts about what was the ultimate virologic failure rate across the 1,224 participants in FLAIR, Atlas, and Atlas 2M. What was the overall virologic suppression rate in an updated analysis at ID week? Was it 0.5%, 1%, 1.4%, 2.8%, or 4.5%? And anyone can venture a thought if they want. And I can look in the chat too. Oh, great. I just saw the chat that you have 40 patients at Bartlett on injectable ART. Great. Any thought about what the overall virologic failure rate was across these 3 trials? I think it's important because it's low. So the exact, no one's putting in the chat, so I'm going to just say that it was 1.4%. So essentially there was a paper published in AIDS, and then there was an updated analysis actually at HIV Glasgow in October that looked across all 3 of these trials and looked at the overall risk of failure. And it was 1.4%. It was low, but it was bad, meaning if you failed, there was a high rate of integrase inhibitor mutations that developed or NNRTI mutations that conferred resistance to rilpivirine. So these are actually all the failures pulled out, and you can see the development of insting mutations. You can see some mutations on there like Q148, G140 that makes you think that dolutegravir is not going to work well. And then NNRTI mutations came out as well. Across these 3 trials, the overall virologic failure rate was 1.4%, and the majority of those occurred early, occurred before week 24. So even in the Atlas 2M study, if you were going to fail at every 2 months of a regimen, most of the failures occurred before week 24. I think that's important when we think about treating viremic patients. So keep this in mind. And then the other question that I have is of the below risk factors for virologic failures, because there were 3 distinct risk factors, which one can you actually get around, circumvent by different ways of administering the injections? Is it low rilpivirine trough concentrations? Is it the HIV subtype you have? Is it high BMI, a history of rilpivirine mutations, or low BMI? And I'd be curious if anyone wants to put in the chat or yell out what your thoughts are. There is actually a particular risk factor for failure that I think there's a way to get around. And Eileen, exactly, I think it is high BMI, because what the 3 risk factors were for failure were essentially in an AIDS paper, and then again, updated analysis at ID Week by Chloe Orkin, high BMI, presence of 2 proviral RAMs, so rilpivirine-associated mutations, can't change that, can't change HIV subtype A6 and A1. But what was it about on high BMI that you could change? Well, this is the first time we've been using injectable agents. For those fields that use long-acting agents, they think all the time about the subcutaneous space, the intramuscular space. How do you ensure that if it's an IM injection that you get into the intramuscular space? And there was data from the European AIDS meeting, and this was a British Journal of Clinical Pharmacology paper that showed that if you have a high BMI, which is a risk factor for failure, is above 30 kilograms per meter squared, that if you use a longer needle to inject the cabotegravir and rilpivirine, specifically cabotegravir in this case, you could get past the subcutaneous tissue into the intramuscular space, get the proper spreading out of that medication, and you actually had higher cabotegravir levels. So we standardly in our clinic, anyone who has a high BMI, and we've chosen as our cutoff 25, we use a 2-inch needle instead of that 1-inch needle to inject our cabotegravir and rilpivirine. So what about some data from CROI? So those were the 3 registrational clinical trials. Those actually led to the approval of long-acting cab rilpivirine in January 2021. But this was data from CROI, which was, of course, after these medications have been approved. This is the SOLAR phase 3B study, and it looked at participants on BIC, TAF, FTC, switched them over to cabotegravir and rilpivirine every 8 weeks. It's not really important that the virologic suppression rates were high. We would have actually expected that. I think what was really interesting from this study was this kind of qualitative data that asked people, why do you want to switch over? Now, it's one thing to be a theoretical, but these were participants who were on BIC, TAF, FTC. And 41% of participants said, I really have a hard time taking even that 1 pill once a day. And the 3 reasons that came out were worried about people unintentionally discovering their HIV status, worried about forgetting, and also that it's just an uncomfortable personal reminder of their HIV status. I actually had the privilege of interviewing one of the cure patients, who was cured, Adam, the London patient, and he said, never underestimate the effect that it has as taking out an HIV medication from your pill box, even if you're on other medications. So these were the reasons that participants wanted to be on long acting, and they switched over and did very well. So that's the data. That's the data in naive and experienced patients. And that, of course, led to the approval in January 2021. You have 40 participants in your patients in the Bartlett Clinic who are on long acting. And one thing I want to say before I go on to kind of novel ways to look at these medications is that there is a world we could possibly imagine someday that would allow for self-injection of these medications. This was data on the left side here from AIDS 2022, and then on the right side, CROI 2023, of giving thigh injections of cabotegravir and rilpivirine. And just in general, essentially, the thigh injections do not show any different PK. The PK is essentially the same as giving in the currently administered place for these injectables, which are in the lateral gluteal muscle. So the PK won't be different. You could give it in the thigh. Importantly, there was actually more pain when the injection was given in the thigh. And there are ways to sort of try to mitigate that. We always warm up the medication. We always rub it afterwards, rub it before, but it's important to know that you can give it in the thigh if that's an ability for it in the future, pharmacists or mobile vans or self-injection to occur. Before I go on to what we've been doing in our clinic, I will mention that of course, there is one other long-acting injectable that's now been approved. It's for a very specific patient population. This is lenacapavir. It's first in kind capsid inhibitor class. It works on more points, I think, of the life cycle than just once the virus has been assembled and then the capsid comes on. So I think that's important when we think about, I'd be curious later to think about Eileen's thoughts about reservoir or about DNA levels, but it may be more deep than after the virus is already assembled. But at any rate, the lenacapavir has been studied in two ways: in naive participants and in multi-drug resistant people living with HIV. Now, importantly, in the naive participants, this is the Calibrate study. This is not going for a FDA indication, because if you look at this study, there's 52 people in each of these arms of looking at lenacapavir, which is a very potent drug. It can be administered subcutaneously every 26 weeks. And lenacapavir is given that way was given with an oral background. And you can tell who makes lenacapavir drug company-wise by what they gave in the background, either FTAF or in one case, actually just BIC alone. But at any rate, very small sample sizes. This wasn't going for FDA approval. The Calibrate study actually stopped, but it looked good. There was a Lancet HIV publication of the Calibrate in January of this year. And then there was updated data from CROI 2023. And essentially in these, again, small groups, 50 in each arm, if you give lenacapavir in naive patients with a oral backbone, which kind of makes you argue, why do I want lenacapavir with an oral backbone? I might as well take an oral pill. And that's probably why they're not going for indication. But there were high levels of virologic suppression. And importantly, there was a certain rate of resistance, 3 out of 157 participants. And their resistance mutations were interesting. They sound like TAMs, but they're not. They're in the capsid gene, Q67 and 70R. But there was some resistance that developed. Then the Capella study. This was the study that allowed for the approval on December 12th, 2022 of lenacapavir to be used in multi-drug resistant patients. These are participants who were on an optimized background regimen, whatever they could get, because there was multi-drug resistance with lenacapavir. Remember, the ultimate dose of lenacapavir is giving it 600 milligrams on day 0, 600 milligrams on day 1. You don't have to give a day 8 dose. That didn't come out in the package insert. It wasn't needed PK-wise. And then you give on day 0 the injectable 927 milligrams every 6 months, so every 26 weeks. So the design of Capella was essentially kind of 2 small cohorts, one who was randomized and one who is not. This was only 72 participants. This was published in the New England Journal last year. And essentially there were high rates of virologic suppression if you got lenacapavir compared to those who were just on the oral regimen, whatever you could cobble together. But having a backbone, meaning having some backup to lenacapavir, was important. And in fact, if you didn't have a backbone, meaning participants who either weren't taking their oral optimized background regimen or didn't have much in there, those were the participants who failed. In fact, out of 72 participants, 9 failed, and all 9 had lenacapavir essentially as functional monotherapy. It means that lenacapavir can never be alone. It really has a low genetic barrier to resistance if it's alone. And these were the different drug resistance mutations that come out. I tend to put all my drug resistance mutations on my phone in contacts. So when I'm lonely, I can call lenacapavir and I can see all of these mutations come up. So if anyone wants to text me after this and get my phone contacts, I have one for darunavir, lenacapavir, the Insties, and one for doravirine. So going, and that's actually just a little side trip that I'll take here, that I do think these are the 12 mutations that every HIV provider should memorize. I always ask the fellows, not make, I guess I make them memorize the 6 TAMs. I think they're important to memorize: the 41, 67, 70, 210, 215, and 219. Then the 3 NNRTI mutations that are of note: the rilpivirine one, which is 138, Y181C, and K103N. And then everything else I have on my phone as a contact, all the darunavir-associated mutations, the lenacapavir, doravirine, and please feel free, I will put my phone number here, and text me after this. And the NIH is visiting us today, but later in the afternoon, I will send you back, that's my phone number. I will send you back these contacts so you can have them in your phone. That way you know if you need to use darunavir BID or can't use darunavir at all. It's not only a great way to use your contacts, but I have 3 friends. I have 3 new friends. Okay, so what about going back to the issue of long-acting injectables, not in the participant populations that have been studied, but what about in non-suppressed patients? I mean, we all wanted it. We all thought about it before the injectables came out. We all wanted to use these medications in patients who we knew were having a hard time taking oral ARTs. It's a critically important population for ending the HIV epidemic. In fact, 10% of people living with HIV in this country, this is a modeling study, are holding 94% of the virus. And if that's true, then it is this patient population that needs injectables the most, or at least needs some novel way to try to suppress. And so what do we know about real world studies of long-acting cabotegravir and rilpivirine? I've just told you about the clinical trials. What about real world studies? Well, I'm curious how many you think there are. I mean, I liked Ethel's comment that doravirine is always texting me so many times. I have so many issues. But so what about real world studies? How many have been done that at least have some sort of publication or abstract out there? Anyone can yell out, because I think more people are looking at in real world and putting out studies, but we only have, Joyce says 1, but actually it's been 6. Now, interestingly, they're small studies. They've been coming out in abstract form, and we don't have a lot of data to put data together to compile them. So what are the studies that we know about of real world studies of long-acting cabotegravir and rilpivirine? The first was actually the compassionate use program by the drug company. Now, this compassionate use program was published in HIV Medicine. It was 35 people who they gave long-acting cabotegravir and rilpivirine to before it was approved. And 28 really weren't virologically suppressed on entry because many of these patients really couldn't take oral. They had short gut syndrome. They had some problem that they could not take oral pills. And so because of that, they allowed the compassionate use. But I will say that out of these 35 patients, they didn't do that well, meaning the overall virologic suppression rate was pretty low. It was 22 out of 35, so 63%. That's not a virologic suppression rate that you want. That's not, the 98% virologic suppression rate overall in the clinical trials. So this was really, think about, this was the first look at using it in non-virologically suppressed patients. And it was really depressing, except that there was no report on percentage of on-time injections. It wasn't the most thorough sort of characterization of these patients. It was hard to tell what was going on. So then what else have we seen out there in the literature? In ID Week, there was an abstract that was presented from the OPERA cohort, which really is just a very real world cohort across the country. And of people who were living with HIV in care in OPERA, 421 had been started out of 105,000 on long-acting cabotegravir and rilpivirine. Now, they only had the data to give us the viral load suppression rates out of 383. And of these 383, a very small number had been started when they were viremic, and 21 had been started when they were viremic. And of those 21, 91% suppressed. So, I mean, very small sample size, but those 19 out of 21 essentially suppressed. Then there was a study out of the Ryan White Care Program in Atlanta. This was done at Emory. This was essentially just 15 patients put this out in OFID. And out of those 15, 13 remained virologically suppressed. None of those patients had started out with viremia, but 2 of them actually failed. And then there are 2 quite large studies, but they're both done by the drug companies. These are real world studies They're done in Europe. One's called the Carlos cohort, and the other is the Carousel cohort. And they are essentially, because they're done by the drug company, only starting long-acting cabotegravir and rilpivirine in virologically suppressed patients. So these are, the first one, Carlos, is in Germany. There were 200 patients that they showed the results at HIV Glasgow, and there was an 89.5% virologic suppression rate. Again, all it started virologically suppressed. So that means there was actually a 2% virologic failure rate. And then some people who discontinued didn't like the medication. So there was a 2% virologic suppression rate. And then the Carousel cohort is across 5 countries in Europe. And the data was presented at ID Week of 430 participants who were virologically suppressed already on oral ART, started on long-acting, and the overall virologic suppression rate was 87%. So there was actually a higher, it wasn't exactly a virologic failure rate. They didn't call it a virologic failure rate. They said that it was, there was a lot of, they couldn't find participants. There was no virologic data. So they said their actual virologic failure rate was less than 1%, but I don't know what's going on with those people who they couldn't find. And I hope they hadn't failed. So, you have to really say that there was an 87% virologic suppression rate in this real world study. These were both done in, really kind of supervised settings, and there was very high rate of on-time injections. So what did we do in our clinic? The Ward 86 HIV clinic, I will say, opened its doors in January of 1983. So just 2 months ago, we celebrated our 40th anniversary of being open. I don't actually think it's the first outpatient HIV clinic. I just went to UCSD, and I think the Owen Clinic may be a little older, but we did open about 18 months after the first description of AIDS cases in the June 5th, 1981 MMWR. Our patient population is essentially publicly insured. 96% are on Medicaid or Medicare, or 4% are uninsured or underinsured. And especially with the pandemic, we have had an increase in really, I think the 3 major barriers to adherence in our patient population are mental illness, a major mental illness on ICD-10, addiction. We have a 35% addiction rate, mostly methamphetamines in our city compared to Baltimore, and marginal housing. A full-on third of our patients are in and out of housing or homeless. So this is our relatively vulnerable population. And the question is, what did we do with long-acting ART when we first got it? Well, we wanted to try it. We wanted to try it not just in the patients that look like the participants in the clinical trials. We wanted to try it in patients who we just could not get suppressed. And that meant we'd have to try it in some patients who are viremic. And so we started a pilot demonstration project to essentially give it out to kind of anyone who wants it, regardless of virologic suppression. We have a very defined protocol. We put it out. It's publicly available on the Getting to Zero San Francisco website. You can download it. And we were particularly interested in the homeless population because in the city of San Francisco, 75% of those who are housed are virologically suppressed, but only 27% were homeless, are virologically suppressed. And we have had increased rates of homelessness during the pandemic. So what were the inclusion criteria of the trials? You know those very well. We went over those. The inclusion criteria at Ward 86 to enter into the program were different. We didn't, well, I will be honest, we did allow at the beginning some minor rilpivirine or INSTI-associated mutations. I'll talk about that. And then later we became more strict and didn't allow any mutations. Essentially, they could be viremic and didn't need to be taking oral ART, but the patients had to express willingness to come to clinic. They had to have contact with the clinic. And that did exclude people who we don't see, who don't come in. So, and we absolutely have a lot of outreach. We call them quite a bit ahead of time before the every 4 weeks to have them come in. So let me tell you about what we found. I will say that we used our existing staff. We didn't have to hire a lot of additional staff, but we did actually hire 1 additional staff for our program. And this was a farm tech, because you'll see that for those of you who've been using it, there's insurance barriers. It's actually easier to get these medications on public insurance than it is on private insurance. And so just with the PAs, we hired a farm tech to help us get the injectables. We have bi-weekly meetings. We had one yesterday that we do not, every 2 weeks we meet and go over every single participant in the program, mostly at least that we're worried about. And we meet with clinical leadership, the PharmDs, and also leadership of our homeless program, which is called our pop-up program. And then we have a protocol and we refine it all the time. We had some issues that I'll tell you about that we should have made. Maybe we shouldn't have let in people with some minor mutations. So we just made it more strict. And now we don't allow people in with minor entity mutations. And I'm going to tell you about the first 133 participants in our program that were enrolled between June 2021 and November 2022. Now, of these 133 people living with HIV who are started on long-acting ART, 76% were suppressed on oral ART and 57 were viremic. They were 68% non-white. A full-on 66% were unstably housed, actually, because we enriched our cohort for those in the pop-up program, which is our program that serves homeless patients. And 74% did get on-time injections. And you could see at the bottom on this table that those who were virologically non-suppressed had a much lower CD4 count. I had a patient who had a CD4 count of 14, who had a viral load of over 1 million. Really, we kind of had no holds barred with viral loads that we would let in, but they had lower viral loads. Understandably, these were patients who couldn't take oral ART. And so what did we find? Well, of the 76 who were virologically suppressed to begin with, they all stayed suppressed. So that was consistent essentially with the clinical trials. This is a small study, but of the 57 who were not suppressed, who were viremic when they started long-acting injectables, 55 suppressed, and they remain suppressed to this day. We now have longer follow-up. 2 failed. That 2 out of 133 does become an overall virologic failure rate of 1.5%, which is on par with the virologic failure rate in the clinical trials, at least so far. And of our 2 failures, they failed early. We knew early on that they weren't going to succeed, because actually what happened is that both of them had a minor mutation. The patient number 1 had a V179I, which is a minor lopivary mutation in the ECHO and THRIVE trials. The second patient had a T97A, which is a minor entity mutation, and they didn't achieve that 2-log reduction by their first visit after getting the induction dose. And in fact, if they didn't go down to 2-log, we already knew we were in trouble, got genotypic resistance testing, put them back on oral ART, or at least tried, and they did develop additional mutations. So just like the failures in the clinical trials, these patients with failure did actually develop additional resistance mutations. But I think this is an important point. Neither one of those 2 patients who failed have been able to go back on long-acting ART. And so I will never regret trying this, actually, because they are to this day unsuppressed, will not take Simtuza, cannot take Simtuza, and they are not on oral ART. So I'm glad we tried, and I'm glad that the 55 patients who were viremic are doing well. So we call this program SPLASH. Actually, it does include PrEP as well, and it's special programs on long-acting antiretrovirals to stop HIV. And what we really want to do is do this in a larger study. What we really want to do is take these take this model that we did at Ward 86 and study this across the ACTG, actually. And we put in a protocol to, or a concept at least, to the drug companies to hope that we can study this across the ACTG. It's still an very active, ongoing discussion. We had a meeting that was organized by the HIV Forum among different stakeholders, drug companies, FDA, ACTG, we at Ward 86, and we all came together in November 2022 in DC and talked about what it would take to change the label indication. And there's sort of 2 ideas about this. Right now, probably the 57 people that we have in our program is likely something that other people are going to do. People are going to start viremic patients on long acting. And if we can pool all that data together, we'll have a larger sample size than 57. And when I presented this at CROI, a lot of people came up to me afterwards and said, oh, we have a bunch of people who are viremic who started this. And I said, well, let's put all that data together so we can put out something to the world. But is that going to be enough? Usually drugs get an FDA indication if there was a randomized controlled study that showed that placebo, this worked better than placebo. But this is not really, in a way, I don't think we have equipoise to do a randomized controlled study, because to do oral ART in patients who cannot take oral ART, you've already really stacked the decks against your control arm. We're trying to study this in participants who cannot take oral ART. And there was a modeling study that was done at Harvard that was presented at CROI, that patient population who have had long-term barriers to taking oral ART, the virologic suppression rate in that patient population is about 22%. These barriers are real. You can't take oral ART. So it would really stack the decks if you try to do a randomized controlled trial and force people to take oral ART when they can't. The A5359 trial in the ACTG is trying to do that, and it is working, but but we don't know the results yet, but they are giving incentives to people to take their oral ART, but they actually had a very difficult time enrolling during the pandemic. So the question is, can you take a single arm trial, and can that get you an indication in the FDA label? Well, that's what got the indication for ibalizumab, for example, in MDR HIV patients, because it's a rare phenotype to have multi-drug resistant HIV. So ibalizumab was just studied in 31 participants actually in the cohort, and it got an indication. Could we do a single arm trial of a very specific population, which is a rare but important phenotype, which is that you cannot take oral ART. It's just too difficult for these different barriers. And can that single arm trial get FDA approval? And what the FDA said to us at that meeting is they would consider that. The other way to get this approved is to get it on the treatment guidelines, is for the treatment guidelines to say, we have data from Ward 86, we have data from Bartlett, we have data from these accumulating clinics. It looks like you can use it in viremic. We have the single arm trial. And if they put it as at least even grade B evidence on their treatment guidelines, then you can show that to an insurance company when you're trying to get it for viremic patients. So I actually wanted to end there and have this be a discussion about long actings, what you're doing, what do you think about what we're doing, and your thoughts. And then I will say that in terms of the questions that have come up, Ethel, no, none of our Ward 86 viremic people were included in the opera cohort report. So they weren't in those 21 people who are viremic. And also, how many of your viremics in our patient population also received lenacapavir? Well, it's a really interesting question. So none of them had, but I told you that 55 out of 57 suppressed. However, one of those 55 suppressed down to 260, and it wasn't good enough. We were getting nervous with their viral load. And when lenacapavir came out, we actually put them on lenacapavir, and they suppressed all the way to less than 30. So to be fair, one of those participants is on lenacapavir, cabotegravir, and rilpivirine. And then Liz asks, are there any ongoing studies of cabotegravir and lenacapavir? So I think this is a tremendously important question, because the reason this is such an important question is, why did the WHO in July of 2022, and remember, often treatment guidelines or new updates in the WHO and the UNAIDS report are often put out in conjunction with the International AIDS Conference. So this was in Montreal in July 2022, and July 28, 2022, big announcement that long-acting cabotegravir every 2 months was endorsed by the WHO as a PrEP agent. But there was a very notable absence of the WHO endorsing long-acting cabotegravir and rilpivirine every month or every 2 months for treatment. And though there wasn't really a specification because they don't actually put out statements why they didn't endorse something. I think that there are probably a couple of reasons why cabotegravir and rilpivirine wasn't endorsed worldwide. One, there is a cold chain. So just to be clear, you can keep the vial out of the fridge for 6 hours. If you draw it up in an injection, it can only stay in the syringe for 2 hours, but you can carry it around for 6 hours. So we have given a few mobile injections in the field. Could be cold chain as one, maybe more minor issue. Second is, I do believe it's what Liz just said. It's really probably the degree of NNRTI resistance in low and middle income countries. With efavirenz being first line therapy for so long, there is a certain degree, maybe 13%, maybe 15%. We haven't had worldwide surveillance for a while, but of NNRTI resistance, and you're going to lose your rilpivirine in that case, especially if you have a Y181. K103 is the only mutation that you can get away with using rilpivirine with, and so there is a concern that if we gave out long-acting cabotegravir and rilpivirine worldwide without worldwide concomitant resistance testing, that the rilpivirine could fail, leaving the cabotegravir unprotected. I think the other one is that if you fail, and you fail with entity mutations, you've just lost first and second line therapy. You've just lost dolutegravir. So I think that this question of lenacapavir and cabotegravir is tremendously important. So at CROI, we had put in a concept sheet to Gilead and to ViiV about using long-acting cabotegravir and lenacapavir in a patient population in the ACTG. What we were proposing was to do it in a small cohort like dolutegravir and 3TC had been studied in ACTG 5353. Remember, dolutegravir 3TC was not started in a phase 3 clinical trial. Dolutegravir 3TC was started in the paddle study. Remember, the paddle study had 18 people in it. We knew everyone's name, participant, we'd memorize everyone's participant ID number because those 18 people were so highly scrutinized, because paddle showed us for the first time that we could use dolutegravir and 3TC in a small cohort. Then it was studied in a phase 2 study, ACTG 5353, in the clinical trials networks, and then it went on to Gemini and the Tango and Salsa and the other studies. So really the question of lenacapavir, cabotegravir, we want to study in a small way in the ACTG in patients with either, like you say, Liz, with NNRTI mutations, and study cabotegravir and lenacapavir. I will say that we have 6 people at Ward 86 who are on cabotegravir and lenacapavir. I just started a patient of mine on it 4 weeks ago. This is a patient who has had HIV for 38 years. He cannot take pills any longer. He has hit a wall. He cannot take them. He is an advocate in the city. He's a long-term survivor. He is well known. He may be the Pride Grand Marshal. I voted for him for July, but he is not going to take oral pills anymore. He cannot. And I started, he had rilpivirine associated mutations. I started him on cabotegravir and lenacapavir. And after only 2 weeks, his viral load went from 1.3 million to 260. So, and then we'll see what his next one is. So yes, we have people on cabotegravir and rilpivirine. I think it's a really important question. And let's open this up to other questions and thoughts and hearing a discussion on this, because I really want to hear what you're doing and your thoughts. And I'll open up the chat as well.
Yeah, Monica, that was amazing. And I think we will have not enough time for all of the things to discuss. I just wanted to ask you, though, real quickly to slide this in, because it's kind of low level and boring, but in terms of the timing of injections. So I remain a little bit concerned about the data where they're when you tell people if you take your medicine every day, you will not fail. I feel 100% confident of that with all the oral meds, and with the injectables, even with on-time injection, there is that very small but present failure rate. And so just wondering, in the not really formal, but sort of just side back of the envelope analysis, where it seemed like that type of failure in the Q2 months was more if you did Q1 month for the first year, you might do better. And what I think I remember from CROI is that all of your patients are on every month injection in your viremic patient study. And so as we think about insurance barriers and other things, what are your thoughts about every 1 month versus every 2 month for cabotegravir specifically?
Yeah, no, this is a tremendously important and real aspect logistical question, which is that which is that absolutely like the PK of I mean, Ethel knows this well, but the PK of injectables are different. It's not really like your injection site matters, your technique matters, the depot formulation that it's in matters, whether you get it in the IM space matters. And we all saw from HPTN 083 and 084 that there was a certain rate of breakthroughs that even occurred with absolutely on-time injections. So that worries us, right? So the question is, what did we do in the viremic patients? We did not allow every 2 months at first. Actually, what happened is that I asked the drug company, they said that 68% of their failures occurred in the first 24 weeks. So, and I had already told you that Atlas 2M showed us that the majority of the failures were early on. So we didn't start off with every 2 months. Anyone who was viremic, we actually mandated that they had to be on it every 4 weeks. First the induction dose, then the maintenance doses every 4 weeks. But once they were virologically suppressed for 3 to 6 months, we allowed even viremic participants to go on to the every 8-week injections. And now of those 133, about now more than a third are on every 8 weeks. But we started out with every 4 weeks. There were 2 studies from CROI 2023 that were interesting in relation to the question that you just asked. One was that analysis that you did, that Craig Hendricks and Mark did from Johns Hopkins about in the HB10 084 study, showing that at least in women who were all enrolled in sub-Saharan Africa, that you could possibly go out to, well, let's just say that there was a lot of forgiveness for cabotegravir. There were high cabotegravir levels, and that even if you went out to 12, sometimes even 16 weeks, that you still had high enough levels and that there wasn't any failures. It gives this question about forgiveness for women with more time between injections, maybe even out to 12 weeks. The drug company and certainly Mark at his presentation was not encouraging going up to every 12 weeks, but it makes you think about forgiveness. That was in women only, and that was certainly in African populations only. But then there was this study presented in the same session at CROI from France, where people had lower levels of cabotegravir and rilpivirine than they thought. Now, they were all men. They all had high BMIs, and they didn't get the oral lead-in because the oral lead-in was dropped by the FDA in February 2022. So it has made us think about our patients with high BMIs, and not only do we do the 2-inch needle, but we just changed our protocol to give them oral ART for the first 2 weeks with the injection, because we want them to have coverage at the beginning. So we're responding in our protocol to data in real time. And then one thing I do want to say to Liz is that this momentum from the drug companies, because we put in a concept sheet to Gilead and ViiV to ask if they would do cabotegravir and lenacapavir. One of the drug companies has said yes, which is Gilead. And the other drug company has not yet said yes. And yes, they would have to uncouple cabotegravir and rilpivirine. They don't actually come as a single injection, and they are uncoupled in a certain way because there is cabotegravir for PrEP. So we're just waiting for them to say yes. We have a call with them next week, and we're begging them. And then Allison says, do you do any community-based, non-clinic based injections? Yes. You know, there were 4 patients out of the 133 that we followed out and that we just found them in the field. We found them in their SROs. Again, the medication can sit for 6 hours at room temperature. So we just took it. It was a medical student on a bike, and she just took in her backpack and she went and found them and gave them their injections in the field. We want to expand that. We want to expand mobile injections, and we're writing a grant to do that. And then Amita says that yes, 10% are holding 94% of the virus. I mean, we'll never end the HIV epidemic without getting this population. I do think we need to push this strategy. I do think that the way we push this strategy is just being kind of bold enough to do it. And what I mean by bold enough is I don't regret those 2 patients that failed, because to this day, they're not on oral ART. They have really low CD4 counts. Just, I would say, do it and then pool our data together. If you're going to do it at Bartlett and put more patients on it, whether clinic-based, whether mobile-based, contact me, contact people who are trying to put this data together. I actually already talked to Hersa, and I said, anytime you think about hear from a clinic that they're putting viremic patients, can you ensure that we all start talking, that we all start, putting our data together, pooling it in using best statistical practices, that we can put out the largest data set possible of viremic patients while we're waiting for the drug company to hopefully approve the single arm trial in ACTG. So I would say do it, because these are the patients that need it the most.
Could that be modeled on the pregnancy registry?
Yes,
I
love that idea. Yes.
Yeah, which is a very well established, still relies on clinician reporting, but centralized data collection, and seems like it would just give a model for early implementation or rapid.
I love that idea. That this idea is, thank you, Gerta. I love this idea that exactly like that. It is voluntary reporting, but why wouldn't you want to report it? And we could all put it together, and then that becomes a registry. That is a great idea. And because I thought the best place to centrally locate that was HRSA, right after CROI, I asked for a call with Laura Cheever, and we presented this data to her. And I said, anytime that you hear about this, or from any clinic, Ryan White or otherwise, please see if people will put it all together. And it was bold. And I will say, I got a lot of pushback, meaning I did it, but it wasn't exactly endorsed by a leader above me, but if you are in the clinic, and you all are, many of you are, your patients. And I'll just tell you a poignant story, but this was a patient, he's 38. He could not take orals. He just could not. He used a lot of methamphetamine. He developed an N155 on dolutegravir that he didn't take every day. He was spreading N155. He was doing sex work, and he just couldn't do it. And he was the one whose viral load was 1.2 million. His CD4 is 14. Totally desperate. Started him on it. On his first injection, he was undetectable. After his first injection, he called his mother from the clinic. He hugged everyone in the clinic. It was amazing. He's been now 18 months, totally suppressed, working again. He's never felt like this. I know we all have anecdotes, but it was so powerful. And when people say, well, why do they come back? Why do you have 74% on-time injections? Because there is qualitative data that Kat Christopoulos has done, and we've just talked to people where they say, I have never been suppressed. Do you know what this feels like to be suppressed for the first time? I have never been suppressed. So we have to do it. We have to do it. And I think Johns Hopkins should be the next one that has a lot of people who are viremic on it, and then we'll publish a paper together.
So Matthew runs our amazing pharmacy program, and I know he's actually been showing his face. So I just wanted to, Matthew, do you want to share anything or ask any questions?
Thank you. I just wanted to ask regarding, I think one of the biggest fears we're on this topic right now is a lot of these patients do struggle, they have adherence issues in the past with oral, and also adherence to clinic visits. And I think there's that fear that, we start them and they don't show, or we're always chasing them down. I'm interested in I know that you said you went out into the field for a few patients. What other outreach engagement strategies did you have to ensure that you're getting those patients back in? And was it a big challenge, or do you feel I know you mentioned getting them suppressed has excited patients and gotten them more engaged, but I'm interested in hearing more about your guys' strategy on that.
Yeah, you are so right. Okay, I just had to praise the HIV pharmacist with all my heart, including you and our 4 HIV. We have 2 pharm techs and 2 HIV pharmacists. But it was them essentially that made this happen. What I mean is that we do a lot of outreach. So we call. So these are not patients who are not engaged with the clinic to begin with. They were engaged. So we are not getting some patients, obviously, who are not engaged. But we ask them to come in every 4 weeks. We ask them to give us contact numbers. We also ask them to give us friends' contact numbers. And we also ask them, if you've been to San Francisco where is your tent? I mean, in your encampment, and if we need to find you. And so we ask for a lot of contact information. We call a lot. We keep on calling. We absolutely offer incentives. We offer a $10 Safeway card to come in. And we also have the kind of power of relationships, which you also have in your longstanding clinic. And so it is work, it is resource intensive. It's mostly from the pharmacists, it's mostly from you, Matthew. And we've gotten them to come in. And then again, I think we do want to expand it to mobile. And that's what we're going to do next. And I didn't know, Allison, that you had published a case series on some of your viremic patients. So that's amazing. And I'll put that in you're going to be the 7th study that has looked at this in the real world. That's great.
Hi, Monica, I'm Joyce, and it's nice to meet you virtually. I'm the acting medical director here at Bartlett. So really excellent talk. We have been talking about doing this. I'm impressed that you didn't have to increase much staffing to implement because it is so resource intensive. And just wondering if you can talk more about the sort of psychosocial support as well. And just really, from my perspective, with all of these patients, high needs patients need more, should get more. And I guess I have 2 questions. One is, do you kind of model having sort of a high needs, high touch subclinic in your clinic where you have certain staff that are assigned? And then just also in terms of resources to be able to really implement. And I think, as Matthew alluded to, and some of the hesitation of doing this is, for these patients, it's more than just an injection, right? Like, they often need so much more. And if it's approved for people who are viremic and they're in places that don't offer that comprehensive support, that could go poorly, it seems.
Yeah, I mean, are you Ryan White Care funded?
Yes.
So, it's really interesting to see that, like, if you really dig down in CDC data, the overall rate of virologic suppression in this country is 66%, but in Ryan White Care clinics, it's 86%. And why is it so much higher in our clinics? Because we have case management, because we have social work, because we have these wraparound services that this brilliant bipartisan program, which I hope never goes away, has always supported. And so we use those same services, meaning case management, incentives, outreach. We already had, in a way, those resources for patients who are high needs. We also had a clinic that was called Pop-Up that we started in 2019, which is for homeless patients. And this is a low barrier access clinic, kind of modeled after Max in UW, where we just let them come in any time of the day or night. Not night, but like day, any time of the day. And so it's low barrier. You don't have to have an appointment. And a lot of our patients were from the Pop-Up program. So we already had these resources and kind of support in play. And then the farm tech who was the only resource that we hired, is very active. Like, this is her whole life. She's just doing these 133 people. Now we have actually 180 people on long acting, and this is all she does. And she is really she's Spanish speaking, she's lovely, she's like really engaged, and she is like our special person who does this. It's not as resource intensive as you think, in a way, because the resources of being viremic and having a CD4 count of 14. I mean, the resources of being sick and of being non-suppressed is also high.
Yeah.
And we're always trying to put resources in them in anyway.
Right.
To get them to take oral ART. Now it's just to get them to come in once a month. It's actually a little easier.
Well, thank you. And I will be reaching out to you so that we
can. Yeah, because I'm going to send you the protocol, because I think the protocol is what you need. We won't do it without a protocol meeting. Like, it's rigorous. Like, we change it all the time. Like, you'll see in this protocol, this data from Croy, we're always going to have it a living protocol.
Thank you.
Thank you. And then we can put a paper together, the 2 clinics.
And Sheila is our nurse manager. Did you have a question?
I do. I have my hand up. Thank you for this amazing presentation. So I just want to know, out of the folks that you are treating, how many do you go out to the street and see them? Because I would love to be able to go out in the street and do this.
Yeah, I mean, we had a medical student visiting us like for a whole year. She was the one who did it on her bike, and it was only 4 people out of the 133, but we want to expand that. We want to expand it, and we want to do it on SROs if we have to, in the tents. I mean, I think Baltimore and San Francisco similarly have a high homeless population.
And then, so how do you staff that low barrier pop-up
Yeah.
population?
Yes, that's a really good question. That was funded originally by AIDS Walk in San Francisco, and then we eventually got the city to support us at 100,000 a year. It's not that much.
Okay.
We basically have the same provider. She's great, Liz and Bert, who does it, and then we have the same group. One nurse, one social worker.
Sure.
I'll send you our pop-up protocol too. If you
That
guys
would be
email me,
great.
I'm gonna put my email in here too. You can text me or email me, and if you text me, I'll send you the context. But if you email me, I'll send you the pop-up kind of program.
That would be great. Thank you so much.
Thank you. It was really nice to talk to all of you.
And Monica, I know we're like over time, but one more, Larry Chang had put in the chat, this question about, you mentioned that you knew you were in trouble with those 2 patients when they didn't get their 2 labs
Yeah.
at 2 weeks. So is
Yes.
that part of your protocol? Just looking for early predictors so we can have those break.
In fact, we do genotype. We do viral loads at every visit.
Okay,
Viral loads at every month, and we have an order set to do a genotype.
okay,
Even if their viral loads undetectable, then the genotype can't be run. But our
Right.
order set says do a genotype
Okay.
until they're virologically suppressed. Yes.
thank you so
It
much
was
for
great
your
to talk to all of
time.
you. Thank you.
We are just so thrilled, and there's so much that we can do, and we're just tremendously lucky to have your blazing the way ahead of us. So thank you.
Thank you so much. I really look forward to working with all of you in doing this long acting and talking to you soon. Thank you for having me.
Have a great weekend, everyone.
you.
Bye.
Bye.